All right. So as you guys are already aware, we treat only adults at the Royal Hospital for Neuro-disability. So this will just be looking at communication disorders that affect adults, and they're acquired. They've happened to people later in life on the therapy wards that we treat. So communication is it's like an exchange of messages. So it could be either the way that you express yourself, and this can be through speaking or writing. So these are messages that you're putting out, or it can be how you understand messages. And this is messages that you're receiving, and you do that through listening or reading. And we'll have a look into much more detail about all the different kind of modes of communication that this covers. But overall, communication is for you to express yourself and to make your needs known, and it encompasses quite a lot of different modes. So the main one that most of us use every day is speech or writing, but then we also add a lot of detail to that through gesture, facial expression, body language. There's also drawing, the use of pictures and symbols. Tone of voice also conveys a lot, and something else that we use in speech therapy is something called AAC, which is alternative and augmentative communication. And this can be high tech, which would be through using iPads or computers, which people can use in different ways to support their communication. They can access it with kind of eye gaze or switches, and there's a lot of different ways of personalizing that depending on what someone can do. So low tech, which is things like paper-based alphabet charts, which again, people can use by pointing or sort of pointing with their eyes. So there's a whole kind of world of communication outside of just speech that we use. And all of these things together, we call it total communication. And if someone has got an impairment in one of these areas, then part of our job is to teach them how to be able to communicate as best as they can in other ways. So using a combination of any of the modes that they have available to them. Okay, so communication is a complex skill. It's something that we do every day without really thinking. But if you have a brain injury, then that becomes a lot harder. And if you have difficulty with any of these things that we'll just run through, and which seems like something that seems like an everyday skill can become a lot harder. So to be able to communicate, you need to be aware of yourself and your surroundings, of your communication partners. You need to be able to think about what you want to communicate, think about things that you're hearing. You need to be able to understand language that you're hearing, and also think about the words that you want to use in your mind. So that's word retrieval. You need to produce a voice, and also to move your mouth to be able to produce speech, which includes motor skills. So anything that includes movement would call a motor skill. And then social skills as well. So knowing when you can take your turn, knowing when it's sort of knowing when someone might not want to talk to you, picking up on their body language, knowing to make jokes, that kind of thing. So it's very multifactorial, and there's a lot involved in the skill of communication. So any or all of these can be affected after an injury as well. So that was kind of covering off the means of how we communicate. So it's all the thinking skills and all the movement and things that we need to actually communicate the message. The reasons why we communicate might be very different depending on where you are. So if you're at work and you're communicating with people at work or school, then the reasons are very different to why you might communicate with your friends sort of after school, or if you're sort of texting or writing online. And then the opportunities also vary as well. So this is, all of these kind of areas overlap and just mean that there's different requirements for your communication. So you'd have a very different style if you're talking to a teacher, someone at the shops who's a stranger, or your mum. So all the opportunities, reasons, and means change depending on the situation that you're in. But hopefully within those, your thinking skills mean that you can successfully communicate. Okay, so this is getting into the detail of what we do at the RHN a little bit more. So it's quite a specific population that we treat. So all the words in green are some of the conditions that we see. So on the rehab wards, the ones that we see most of all are traumatic brain injury or stroke. But we also have our long-term care wards where we see more of the progressive neurological diseases. So I'll just run through these in a little bit more detail. So a traumatic brain injury or a TBI might be if someone's had a fall, they might have been in a car crash, or they could have been in an assault, and that would cause some kind of injury to the brain from trauma. There could also be a brain injury from a heart attack. So when a heart attack happens, it can stop the blood flow to the brain. And then the brain needs blood and oxygen to function. So if it's deprived of that, it can cause an area of damage or kind of cell death in the brain, where it's been deprived of oxygen for a certain amount of time. The longer that the brain goes without oxygen, the worse that damage can be. There can also be brain infection, brain tumor. So various things that happen within the brain to kind of disrupt the tissue of the brain. Then another common one that we see is stroke. And within strokes, it can be hemorrhagic, which is when there's a brain bleed, or ischemic, which is when there's a blood clot that blocks the blood flow to the brain. So, excuse me. So again, the blood flow to the brain is very important for delivering oxygen so that it can function. Then your progressive neurological diseases are things like Parkinson's, or Huntington's, multiple sclerosis, or dementia. And all of these are things that affect the nerves within the brain and how they communicate with different parts of the brain and with the body. And the term progressive means that it develops and unfortunately gets worse. And the neurological part of that just means it happens within the nervous system, which is the brain and the spinal cord. And then there's also learning disability, which can affect things like communication and swallowing as well. So the first thing that we're going to look at, which is a condition that can happen after a brain injury, is something called aphasia, which is total or partial loss of the ability to use and understand language. And it can be on one modality of language, or it could be on multiple. It means that it could be on the way that you express yourself, which again is just any way that you can get a message out into the world. So that's speech, sign language, writing, drawing, and gesture. Or it could be on how you understand other people, which is when you hear a message or when you can read a message. So depending on where the damage is and the extent of it, it could be on multiple different modalities or just on one or two. And then the severity can vary as well. And we do kind of categorize different types of aphasia as well. So there's different names depending on the different characteristics. So there's different areas of the brain that control different functions. So it could be expressive aphasia, receptive aphasia, fluent aphasia is when people are, they have a lot of language and they might be talking a lot and they might think they're making complete sense. But a lot of what they're saying actually isn't real words. So they might be saying words that mean completely different things, or they might be words that actually aren't words, they're non-words and it's jargon. And then global aphasia is the most severe type, which is when there isn't any sort of primary sort of strength to communicate. So it means that they really kind of without their language and all kind of care needs to be done in their best interests. You really need to interpret what they might need because they're not able to tell you. And then you can look up all of these examples as well on YouTube for a bit more information. And then when we're treating aphasia, it can be impairment based, which is when you really focus on the area of the impairment. So it could be spoken or written word production, if that's where they're having their difficulties, or it could be with their visual processing of language, which could be reading, or their auditory processing, which is how they hear language. So there's lots of different therapy types that we might use within those, depending again on the patient, what their needs are, and how severe it is. And then therapy is focusing on participation. So this is what we might refer to as being a bit more functional. So things that can actually help them get on with their kind of daily activities. So communicating with their friends and family. And things might be, we also call this kind of compensatory strategies. So things like talking around the word. So quite often a feature of aphasia is not being able to think of the right word that you want to say. So often patients will describe it as feeling like they've got a word on the tip of their tongue. So we teach a strategy called circumlocution, which is talking around the word. So if that word was, if I was trying to ask someone to pass my phone, I might say, oh, it's that black square, you talk on it, and you can do a little gesture as well. So, you push the buttons. And then the aim of that therapy is that either the patient or the speaker then can figure out what word they wanted to say, or the person they're talking to can pick up on enough of their cues that they can say, oh, you're thinking about your phone. Okay, I can pass you your phone. So it's just managing different strategies that they can use to help them and their communication partners. And then within aphasia as well, we might use AAC, which is the high and low tech options that I spoke about earlier. So maybe some iPads, maybe some communication charts as well. Okay, so I've got some videos for these ones. So the next condition that we'll talk about is a motor speech disorder. So motor speech is different from language because the language is actually the content of what you're saying, and motor speech is how you actually say it. So it's more to do with the coordination and the strength of your muscles. So I'm going to play a video of a man who has a dysarthria. Dysarthria can cause weakness or reduce coordination or paralysis in the muscles that you use for speech. And this is caused by damage to the nervous system, so the brain and the spinal cord. And when we're watching this video, this man has difficulties with his output, which is his speech production. So his speech has a different speed because he has reduced strength with his muscles. So it comes out quite slowly because it's a lot more effortful for him to actually coordinate the movement. So just have a little listen to his intelligibility and how easy it is to actually understand his messages. Okay, great. Okay. So basically in the video, it was a man who his intelligibility was really affected by his dysarthria. So he was speaking in sentences, but a lot of it wasn't really very easy to understand. So his first couple of words were pretty easy to hear, but then the intelligibility of his message really trailed off. And that is after the muscles start to get quite tired, the coordination really kind of goes all off skew. So if you think about if you're kind of going for a run and you kind of start to get floppy legs and you think like your muscles just aren't doing what you're telling them anymore, it's that kind of similar effect, that fatigue on the speech system. So it really impacts intelligibility. It makes speaking a lot harder for people. And it their quality of life because they're not able to kind of communicate what they want to say. So it's very frustrating for patients. And we manage that through speech exercises that will target kind of the range of movement, the strength, and the coordination. So it could be practicing sounds and then words and then sentences and then kind of speaking in conversation. So you kind of build from the smallest building block up. And then you can also introduce compensatory messages, compensatory approaches. So rate control. So that could be the rate of speech. So if you know that someone is easier to understand when they're talking slowly, but they tend to speak a lot faster, then you can start to introduce like a metronome approach where you kind of pace them and they talk a bit more slowly, so that they can kind of maintain that intelligibility for a bit longer. You can change the environment, so you can make it quieter, so turning off things like the TV, the radio, taking someone into a quieter room if there's lots of background noise. That can really help them as well. And you can also teach them total communication strategies, like incorporating lots of gesture into what they're saying. So it adds another layer of communication into their day-to-day. And we can also use communication charts as well if they do need that extra support. Excuse me. Another motor speech disorder is apraxia of speech, which is a difficulty with the initiation and the control of speech. So it's similar to dysarthria, but a key feature might be that someone is kind of, we call it groping for the word. So their mouth might look like it keeps trying to start to say the word, but they're just not being able to get it out. And it's that real initiation problem where they just can't quite kickstart into it. And it's that difficulty moving the muscles in the face, the mouth, or the throat to actually say what you need to say. And it can change the way that words sound. It can change the kind of the rate of speech, the intonation, sounds, and the rhythm. And it can come out quite sort of like flat and robotic. So dysarthria and apraxia kind of sit within the speech umbrella, but there are different features of each one as well. And the way that we manage this is, again, kind of speech exercises. And there's an approach called minimal pairs where two words are very similar, but there's one sound in them that's different. So like pie and pie, just to sort of build up that practice of the target sounds. Or there might be clear distinctions in the vowel sounds like E or. Or there might be, we might kind of put together a list of key phrases that are really functional for them. So if they really like drinking tea, then we might practice saying, I want a cup of tea, and they have to finish that sentence. And then there's also a lot of kind of modeling and cueing as well. So modeling the mouth shape to actually create that sound. And then there's also voicing problems, and this can come from problems with the vocal cords, and this might change the pitch of your voice, the volume. It might be very breathy, and this can be quite upsetting for patients because they just don't sound like themselves anymore. It might be very hoarse. The pitch might be very different. So we don't specialize in voicing at the RHN, but we could kind of assist in the diagnosis of voicing problems. And then vocal exercises can be used, breathing exercises, and again, communication charts are always in our toolbox for supporting our patients. So those are the kind of the core kind of speech and language disorders, but then cognition also plays a really key role in communication. So cognitive communication disorder is something that is part of language, but it's more led by the cognition parts of the brain than the language parts of the brain. And it comes about from problems with attention or concentration. So if someone's very distracted, they might not be able to focus on what you're saying. Memory problems, so they might not be able to remember what you said. It might seem like they're not really listening. They might interpret what you're saying very literally. So it could be that they don't understand humor, or they might sort of they might not understand jokes. They might not be able to problem solve or come up with kind of sequencing. So if you said to them, how would you make a cup of tea? Their sequencing might be really out of order. They might not actually be able to explain something that previously they would have done every day. They might have really slow processing of information. You might have to wait sort of 10 seconds after you said something for them to be able to respond, and also impact their social communication skills. So things like eye contact, turn taking, And they might not be aware of what they're doing either, so they might have reduced insight into that. Okay, I'll say this all on this slide here. So this kind of just summarizes what I've said already. But other things that might impact their communication are long pauses within the discourse. So that kind of comes back to that information processing delay. They might not be able to maintain the topic. So they might have something called poor topic maintenance. So it means they might go off on tangents. And they might not kind of allow the other speaker time to take their turn. So it can lead to quite ineffective communication. And they might not have much insight into it. So they might need quite a lot of support from communication partners as well. Okay, and how we manage this with patients is reorientating them. So just letting them know what our role is, reminding them where they are and their reason for admission, raising their insight into the reason why we're targeting what we're targeting. We might use videos and play the video back to the patient and ask them to kind of provide feedback on how they thought that conversation went, and provide education around brain injury and their brain injury and how it specifically links to their impairment and what we're seeing. We'll do a lot of work with family members as well. So conversation partner training is involving people that are their key communication partners and kind of facilitating conversations between them and then having them both feedback to each other what was helpful, what wasn't helpful. And again, just trying to make therapy as functional as possible so that it's not just like sitting and doing drill practice. It's got to be meaningful, otherwise it won't really sink in and it won't actually help anyone. So really making helping to involve the families, involving the people that they'll be talking to on a day-to-day basis, and trying to tailor it so that it's kind of falls within real life activities that they'll be doing. So it might be ordering food from a menu or going to a cafe and ordering a coffee. Community trips to Sainsbury's to put together a recipe, shopping list based on a recipe, and then just handling those communication interactions out in the real world as well. Okay, and this is just a nice quote. So the way that we communicate with others and ourselves ultimately determines the quality of our lives. And I think this is really really important to consider how communication is important day to day. And if someone has a communication impairment, how it does impact their quality of life, thinking about how many messages we communicate every day to make our needs known, to talk to our loved ones. It's really, really important to kind of facilitate that and to give patients as much independence and autonomy on their lives as possible, which is why we do what we do. And